Hello everyone. Welcome to the third session for our MRCOG Part 2. I am Dr. Devyani, your mentor at Just MRCOG. Today we will be discussing a very important topic, that is female genital mutilation. This is an important topic not only from the exam point of view, but also if you are a doctor practicing in the NHS UK. So we will see what the important questions are which can be asked and also refer to the Green Top guidelines simultaneously. All right. So we'll start with the questions now. The first question, a 17-year-old primary gravida came for her booking visit. She gives a history of FGM type 3 in her childhood. What does law say about reporting such a case? Let's see what the options are. A. Inform the police within 1 month from the time of delivery. B. Inform the police within 1 week from the time of examination. C. Inform the police within 1 month from the time of examination. D. Inform the police within 1 week from the time of delivery. And E is respect her confidentiality and not report. Okay, that is what the E option implies. So we know that a girl who is less than 18 years old, there is a mandatory law. It always has to be reported to the police in case she presents with the FGM or if she gives a history of FGM. Let's see what the answer is. Yes, the answer is C. Inform the police within 1 month from the time of examination. So you can see what the Green Top guideline says. If FGM is confirmed in a girl under 18 years of age, reporting to the police is mandatory. And this should be done within 1 month of the confirmation. That is, you are sure that she has been undergone FGM, there is a history of FGM. This can be either found out on examination here or because the patient says so, or if the parent says so that it has been done, you have to trust them and the reporting has to be done. It is a mandatory thing. All right. Let's move to the next question. A girl presents with genital piercings. What the type of FGM is? So for this question, we must know what the types of FGM are. Type 1 FGM, type 2 FGM, type 3 FGM, type 4 FGM, or is it not an FGM? So for this, the genital piercings part comes under FGM type 4. Let's see what the answer is. Okay, this is the classification of FGM. Type 1 FGM, type 2, type 3, and type 4. You can see this highlighted part here. Piercings comes under type 4 FGM. Let us revise what the types of FGM are. Type 1 is partial or total removal of the clitoris and or the prepuce, that is clitoridectomy. Type 2 is partial or total removal of the clitoris and the labia minora with or without excision of the labia majora. Type 3 is narrowing of the vaginal orifice with the creation of covering seal by cutting and appositioning the labia minora or the labia majora with or without excising the clitoris. And this is called as infibulation. That is closing the scar, creating a narrow space. That is infibulation. And the treatment for type 3 FGM would be known as de-infibulation. That is opening the scar. All right. Coming to type 4 FGM, all other harmful procedures to the female genitalia from non-medical purposes. For non-medical purposes, like examples are pricking, piercing, incising, scraping, and cauterization. All this will come under type 4 FGM. So questions can come from any one of these and we should know all the types of FGM. All right, let's move to the next question. A 20-year-old primary gravida came with type 2 FGM. What has to be done? You have to record it in the HSCIC dataset. Option A. B is inform the police within 1 month. C is assess her. D is report it to the police again. Or E is plan. What will be your answer in this case? She is a 20-year-old. Okay, write your answers in the chat box and we shall see what the answer is. Answer is record in the HSCIC dataset. So you should know what HSCIC stands for. It is Health and Social Care Information Center. Let's see what the GTG guideline says. When a woman with FGM is identified, the health professional must explain this law to the FGM to the patient, whoever comes, also to the relatives. And they have to be sensitized regarding it. right? They have to be made familiar with the requirements of the HSCIC FGM, the doctor, right? The health professional must be familiar with the requirements of the HSCIC FGM data set and explain the purpose to the woman, why it has to be entered in this data set. And also this thing is very important, that the entry should be done without anonymization. That means her details will be entered, her name would be entered there. Why this is done? Because we need to prevent duplication of data. Again, her name should be not repeated twice, and hence it will be done without anonymization in this HSCIC data set. Okay, and then she should be told that all her personal data would be anonymized at the point of statistical analysis and publication. So it would be anonymized other places, but here in the data set, the first time when the data entry is done, it would be done without anonymization. She should be assured that later on her details would be anonymized. All right. So now we should know what the sequence of events will be. First, the healthcare professional must explain the FGM law to the patient and the relatives as well, assess the patient, examine her, record it in the data, report it to the police in case it is required. That is, if she is less than 18 years of age, or if there is any foul play suspected, she is under any threat, any legal conditions, these all have to be reported to the police. And the last thing would be planning of the management. Now, this patient is a primary gravida, right? So we need to plan her accordingly. If she has to be given any further treatment, referral to the psychosexual referral services, all this has to be planned for, and that would be in her ANC care plan. All right. Moving on to the next question. A patient from Africa who had undergone FGM presents for de-infibulation. What is the type of FGM she had undergone? So we just now saw that infibulation comes under type 3 FGM. So de-infibulation is type 3 FGM correction. So if type 3 FGM is the type of FGM she had undergone, now she wants to undergo de-infibulation. So here the answer would be C, type 3. Right, we saw this table already, all the 4 types of FGM. Okay, we should know all these terms. Infibulation means narrowing of the vaginal orifice through the creation of a covering seal. That is included in type 3 FGM. De-infibulation or defibrillation means opening of the scar. This is the management for type 3 FGM. And what is re-infibulation? Is closing the scar again. So after the patient undergoes defibrillation, that is opening of the scar, if she requests you that I want to close the scar again by doing this re-infibulation, this is in the law, it has to be refused and it is prohibited. And the law says that re-infibulation cannot be done strictly. Okay. This also is an important question. Okay, now we have an EMQ here. A patient with type 3 FGM is planned for elective cesarean section. What is your next step? So in this question, it says that she has undergone type 3 FGM, but because of some other reason, maybe placenta, accreta, postcreta, we don't know that, but she has been planned for elective cesarean section. What would your next step be? And options are regarding the de-infibulation, right? So when should de-infibulation be done? Let's see what the options are. De-infibulation before discharge, B, de-infibulation before cesarean section, C, de-infibulation after discharge, D, recommend perioperative de-infibulation, E, inform the social services, F, record with anonymization in the HSCIC dataset, or G, inform the police. Okay, so now this patient has been planned for cesarean section and her de-infibulation has not been done yet. So it has to be offered to her. And when will you offer her? Before her discharge or before her cesarean section? Or other options? Think of an option, what you think is right. We shall see what the answer is. And what is the answer? Recommend perioperative de-infibulation. Let's see what the guideline says. A woman who has been planned de-infibulation, but it was not performed because of delivery by cesarean section, right? If she had a normal delivery, it would have been offered to her before the delivery, right? But now if she is undergoing cesarean section and because of this reason, de-infibulation was not done, she should have follow-up in a gynecology outpatient clinic or a FGM clinic so that de-infibulation can be offered to her before a subsequent pregnancy, right? So what can you gather from this is that she can, after the cesarean section, the de-infibulation can be done. It can either be done in the gynecological outpatient clinic after discharge, or it can be done in a FGM clinic as well. right? So let's again see the options. Defibrillation before discharge can be done. Yes. Before cesarean section, she already has been planned for cesarean section now. So that would not be an option. After discharge can also be planned, like we read just now in the gynecological clinic or the FGM clinic as well. So recommend perioperative defibrillation is an appropriate option. It will include everything. That is, it can involve either the FGM clinic or the gynecological outpatient clinic as well. So perioperative is a better option in this case. Right? Let's see other guidelines as well. What it says, how should intrapartum care be managed for women who has been identified having FGM in pregnancy for whom there was no documented plan of care? Agreed. So this impact of FGM on labor and delivery should be sensitively discussed and a plan for care should be agreed upon. And if it has not been done, what can be done? Defibrillation in the first stage of labor can be offered to her if it was not done earlier. Defibrillation can be performed at the delivery as well, at the time of delivery under local anesthesia. Okay, if vaginal access is adequate, then defibrillation can be performed at the time of delivery as well. So these are the time periods where timelines is very important. If they were not done in the antenatal period, they can be also done in the first stage of labor. They can be also done in the second stage of labor at the time of delivery. All right. And now if she has been planned for cesarean section, you can do it in the perioperative period in the gynecological outpatient clinic or in the FGM clinic as well. Let's move on to the next question. Question 6 now. A 45-year-old woman came with heavy menstrual bleeding. She has a history of FGM and has never been sexually active. Next step, right? So now this is a 45-year-old woman. So mandatory reporting to the police will not be an option. So option C is eliminated here. Psychosexual counseling. Yes, this is a thing which has to be done in case she is having any history of trauma, post-traumatic stress disorder. If she reports with any flashback of the events, if she is scared with the sight of blood or anything like that, such question, if there's something of such sort is mentioned in the question, psychosexual counseling will be your option of choice, but not in this case. Here she is presenting with heavy menstrual bleeding. So here treating the HMB now is the correct option. Other options like psychosexual counseling, recording in the HSCIC, informing the police and defibrillation, this would not be right now. Informing the police is not to be done in a case who is a 45-year-old. We just have to offer her informing the police. If she agrees, then we can inform. Otherwise, it is all the patient's wishes here, okay, as she is more than 18 years. So informing the police also will not be an option. Defibrillation is done in case of type 3 FGM, but here we do not know what the type of FGM is. That would not be an option. Recording in the HSCIC dataset has to be done, but this is not the first step which is to be done as she is presenting with a complaint of heavy menstrual bleeding. All right. So the options E, that is treat HMB now, would be correct. Okay, so first you treat the heavy menstrual bleeding and then go for recording the HSCIC. A presenting complaint should be dealt with first. All right. Now, question 7, again an EMQ here. A woman with type 3 FGM has been planned for cesarean section, but defibrillation was not done. When should it be offered? We have seen this question. When should the defibrillation be done? It should be done perioperatively, right? But I cannot see that option here. So let's see what the options are. A, defibrillation after cesarean section. B, defibrillation in the gynecological clinic. C is defibrillation should not be offered at all. D, defibrillation after 4 weeks. E, defibrillation after 6 weeks. F, defibrillation after 12 weeks. G, defibrillation after 6 months. So we saw that it can either be done in the gynecological clinic or it can be done in a FGM clinic, right? So here option A, after cesarean section, can also be an option, and B, that is in the gynecological clinic, can also be an option. So here A option seems to be more correct than B option. Let's see what the answer is. Yes, defibrillation after cesarean section. So this can include both the things, that is in the gynec, it can be offered to her in the gynecological outpatient clinic or in the FGM clinic, right? So after cesarean section is a broader option and that should be selected. Okay, let's move on to the next question. Question 8. A 30-year-old primea gravida presents at her booking visit at 12 weeks of gestation. She gives a history of FGM type 3, that is, infibulation was done, and vaginal orifice admits only one finger. So when should she be offered de-infibulation? Now she is at 12 weeks. When do you offer de-infibulation? Let's see the options. A, as soon as possible, B, around 20 weeks, C, at 28 weeks, D, at the time of delivery, E, no defibrillation needed at all. Right? So now we can see that she is having a difficulty in vaginal examination as it admits only one finger, and we need to offer her defibrillation. When should it be done? Keep your answers in the chat box and we shall see what the answer is. Around 20 weeks. Okay. What does the guideline say? For women with type 3 FGM, where adequate vaginal assessment in labor is unlikely to be possible, defibrillation should be recommended antenatally, usually in the second trimester, typically at around 20 weeks of gestation. Okay. If the woman prefers defibrillation during labor, as this is the usual practice in some countries where FGM is prevalent, that should be offered to her. All right. So first thing is you should offer to her the defibrillation in the second trimester, and if it is not done that time, then you should keep in mind that some women may prefer it during the time of labor as well. So you can offer it during the first stage of labor also, and also during the second stage of labor, right? So all these, so first is antenatally in the second trimester and second is during labor, right? So around 20 weeks would be the option in this case now, as she is at 12 weeks. Move on to the next question. Okay, an EMQ again. A 38-year-old with FGM is a mother of a 7-year-old healthy female child already, and she has now given birth to a male child. Using FGM risk assessment tool, the baby was assessed to be low risk. What is the next step for the mother? Now, this patient has already given birth to a male child. This is a second child. She already has a female child as well, who is 7 years old. What will you do now for the mother? A is inform the police, B is inform the child safeguarding services and social services, C is document in the HSCIC without anonymization. Yes, documentation has to be done. Informing the police would not be done as she is 38 years old. Now, question is regarding the mother, so this option would not be correct. Inform the child safeguarding services. What is D? Document in the HSCIC with anonymization. No, as we read just now, it has to be done without anonymization. E is offered defibrillation after 6 weeks. No, defibrillation has to be done perioperatively, that is in the gynecological clinic or in the FGM clinic. F is refer to the psychosexual services, not required right now immediately. G is oversew the edges and repair the tear. We don't know what the type of FGM was again, so we cannot choose this option as well. So I think C option, that is document in the HSCIC without anonymization, can be right. Let's see what the answer is. Yes, document in the HSCIC without anonymization. We read this now, just now. We need to explain the UK law on FGM to the patient. First, the doctor, health professional must know about the intricacies of the law. They must be explained to the patient, and the health professional must make himself or herself familiar with the laws as well. And entry has to be made in the HSCIC data set. All right, this has to be done without anonymization. So that is our answer. Next question. A lady in her second trimester with history of FGM is requesting cesarean section as she's scared by the sight of blood and worried that she might have flashbacks of the incident. What would be your advice? Now here she is in a post-traumatic stress disorder kind of a thing. She's scared by the sight of blood. So psychosexual referral should be one of your options in the mind. Okay. Let's see what the options are. Urgent referral to the perinatal mental health services, routine referral to the perinatal mental health services, urgent referral to the senior psychiatrist, routine referral to the senior psychiatrist, or accept her request of a cesarean section. Right? So this is a patient who is scared, who is anxious, worried, having flashbacks. She definitely needs referral to the perinatal health services. Okay. But should it be a urgent or a routine referral? Now she is in her second trimester only. Delivery is not imminent or anything of such sort. So a routine referral would be better than no need of an urgent referral here. So we'll choose this option B, routine referral to the perinatal mental health services. Let's see the answer. Yes, routine referral to the perinatal mental health services. As there is no urgency right now, she is in her second trimester. We can routinely refer her, right? Moving on to the next question. A 35-year-old woman presents with complaints of heavy menstrual bleeding. She has a 12-year-old daughter and she's going to travel to the country where FGM is common. She asks you if it is safe to travel with her daughter. While you await your consultant's advice regarding this matter, the woman has already left with her daughter. Now, what will be your immediate next step? A. Inform the child safeguarding services. B. Do nothing. C. Inform the local services to inquire about the risk. D. Inform the midwife. Or E. Inform the police. Okay, what do you think the answer is? Put it in the chat box. Mhm. So she's a 35-year-old. So informing the police is not the option. Now, informing the midwife would be done, but if she's at a risk, if the baby is at a risk, we'll see that question ahead as well. This will be done. C, inform the local services to inquire about the risk. And nothing, or child safeguarding services. First, in this case, now she is going to travel and she has gone, right? And you were going to take your consultant's advice, but you were not, before you spoke to the woman, she left. So in this cases, we have to inform the local services. We need to inquire about the risk. So a risk assessment has to be done, and accordingly, she has to be categorized as high risk, low risk, and the further plan of action is then taken into consideration. Okay, let's see the answer. Inform the local services to inquire about the risk. First, the risk assessment has to be done. Okay, if you suspect a child may have FGM or is at serious risk of FGM, having considered their family history, then what should you do? Referral is done. It is initially often to the local children's services or to the multi-agency safeguarding hub. Okay. Now, if you identify that a child or vulnerable adult has a family history or details which mean she may be at a risk of FGM, but you do not have information to suggest that the risk is imminent or you would not describe as at serious risk. So what should you do? You should follow your local safeguarding procedures, right? And local safeguarding services, the local safeguarding lead, all these have to be informed. A risk assessment has to be done, and then further actions have to be taken. So your option would be informing the local services to inquire about the risk. Okay. Moving on to the next question. A 30-year-old primary gravida with history of type 2 FGM presents at her booking visit. Vaginal examination was done without any difficulty. What would be your advice? Now here, there is no problem in doing the vaginal examination. It's not given like any one finger is being admitted or if there is any difficulty, right? So let's see what the options are. A. Defibrillation during the first stage of labor. Defibrillation during second stage of labor. Defibrillation is done for type 3 FGM. So A and B are not our options. C is elective cesarean section at 38 weeks. Now this patient, there is no difficulty in vaginal examination. So elective cesarean section need not be done in this case at all. There is no other obstetric indication as well which has been given, right? So C would not be our choice. D, defibrillation at 20 weeks again not required. E, episiotomy only if required. Yes, this is our answer. Let's see the answer. Episiotomy only if required, okay? Because she has no other high risk factors, no indication for cesarean section, and no difficulty in vaginal examination as well. So we would be offering her episiotomy only if required. Let's move on to the next question. A 17-year-old girl who has recently immigrated to the UK with her parents presents to the gynecological outpatient clinic with complaints of irregular periods. She gives a history which is suggestive of FGM. As a doctor practicing in the UK, what is the appropriate action would you take? We know she is a 17-year-old minor. First action would be reporting to the police within 1 month of the examination or confirmation of the FGM. All right. And also recording in the HSCIC dataset has to be done without anonymization. Let's see the options. A. Inform the police within 1 month. B. Treat her for irregular periods only as this is the main complaint. C. Reassure that FGM is a known practice in many of the countries as per their cultural beliefs. D. You are not obliged to inform the police. No, we should inform the police here. This D option is gone now. E. Confirm with the parents if the FGM was done in safe and hygienic practices. No, E is also not right. We have to inform to the police. I think A option is the best option out of these. Let's see the answer. Yes, inform the police within 1 month. If FGM is confirmed in a girl until 18 years of age, either on examination or because the patient says so, or if the parent says it has been done, reporting to the police is mandatory and this must be done within 1 month of confirmation. All right, let's move on to the next question. A 19-year-old girl who recently immigrated to the UK with her parents presents to the gynec clinic. So this question is the same as the previous one, only the age has been changed here. Okay. Now this is a 19-year-old girl who has immigrated to the UK. Her parents present to the gynec outpatient department with complaints of irregular periods. She gives a history which is suggestive of FGM. As a doctor, what should you do? Again, the same thing. 19-year-old girl, it is not mandatory to do report to the police, right? You have to offer all the treatment to the patient, and offering to the reporting to the police also, we might ask if the patient wishes to do so, and then if she says yes, then it has to be done. So all the patient's wishes have to be respected now, as she is more than 18. All right, let's see the options. A, inform the police within 1 month. B, treat her for irregular periods only, as this is her main complaint. C, reassure her that FGM is a non-appropriate practice in many countries as per their cultural beliefs. D, you are not obliged to inform the police if it was done with the girl's consent. E, confirm with the parents if FGM was done in safe and hygienic practices. Now here she is presenting with irregular periods. Here you will treat her for the irregular periods and also offer her if she needs to be informed to the police, right? So treat her for irregular periods only, as this is a main complaint, is one of the options which we can select. Okay. Right. So here that this is one of the appropriate options. If the option was that treat her for irregular periods and offer her in reporting to the police, if the patient accepts, then report to the police, that could also be selected if all these options are given in a single option. Okay. Let's see what the FGM guideline says regarding adults. There is no requirement for automatic referral of adult women with FGM to adult social services or to the police, and the healthcare professionals should seek support women by offering referral to the community groups who can provide support. So this is supporting this women is required. Community groups have to be referred to, and for possible clinical intervention, we need to be aware that clinical intervention has to be given if she's having any complaints like irregular periods, heavy menstrual bleeding, that has to be treated. The wishes of the women must be respected at all the times. Okay, moving on. Patient with history of FGM delivers a baby boy. What would you advise before discharge? Now let's see the options. Document the maternal history of FGM in the baby's records, that is the red book. Inform the safeguarding midwife. Informing the health visitor. Informing the GP, or discharge as no risk to the patient. Okay, let's see what you think the option is. Put it in the chat box and we'll see the answer. Okay, the answer is document maternal history of FGM in a baby's record book, that is red book. This is the FGM flowchart, and this patient has already delivered. See the highlighted part, what it says. In the postpartum period, documentation of the maternal history of FGM in the personal child health book, that is the red book, has to be done. That is the child's records. Okay, so here the answer would be recording in the red book. Okay. Patient with a history of FGM now delivers a baby girl. Previously, in the last question, it was a baby boy. Now it's a baby girl. What would you advise before discharge? Now, here also recording and everything is very important, but specifically for a baby girl, informing the safeguarding midwife is an important thing which has to be done, because this girl is also at a risk of undergoing FGM and we have to protect her against it. So, a safeguarding midwife will be taking proper follow up of the patient and the child, and hence this safeguarding midwife is very important here. The other options, health visitor, GP, and discharge at no risk, would not be our choices. We have to inform the safeguarding midwife, right? Right. See the second point here. Recording is also to be done, but here we need to be aware that she is a baby girl, she is at a risk of FGM, and hence a safeguarding midwife has to be notified, who will then inform the GP and the health visitor. So the first point of contact would be the safeguarding midwife for the patient, right? Okay. So this is the last question now. A 20-year-old woman presents to the A&E with a cut in the genitalia. She insists that this injury is because of a result of a horse riding. So what will you do? Will you inform the police? She is more than 18 years old, so this is not mandatory. Only treat the injury and respect the patient's wishes, not to report. Yes, this will be done. We have to respect the patient's wishes. Inform the A&E consultant, inform the social services, treat the injury and inform the police. No, police informing is not required. And A&E consultant, social services also, oh, she's a 20-year-old, we will not be doing these things first. We will be treating the injury and respect the patient's wishes of not reporting. All right. So B option is right. Yes, only treat the injury and respect the patient's wishes not to report. We have already seen this regarding adults. There is no requirement for automatic referral of adult women with FGM to the adult social services or the police. Okay. Then the healthcare professional should seek to support the women by offering referral to community groups who can provide support, and also for possible clinical intervention. The wishes of the women must be respected at all the times in case she is an adult, right? If she is a minor, less than 18 years old, then mandatory reporting to the police has to be done. Okay. I think we've finished with all the questions, right? So these are some of the important charts and flowcharts from the FGM guideline, which you should know. Plan of care for women with FGM in pregnancy. If she's presenting in pregnancy, you have to designate a midwife or an obstetrician with responsibility for FGM. Okay, consultant-led care is very important. This can be one of the questions again. Consultant-led care is required, but there are some instances where midwifery care is also to be done. Come here, okay? In the interpartum part, let's see the second point. Midwifery-led care. I've highlighted this part. So some women may be considered low risk and suitable for midwifery-led care if history of previous uncomplicated vaginal delivery is there. So in these cases, a midwifery-led care can be done for the patient. This is also an important question. Okay. So now again, let's come to the top part. If she presents with FGM, what will you do? Child safeguarding risk assessment. Child safeguarding risk assessment is done. Risk assessment tool is to be filled up. Recording of the data and clinical management plan has to be made. Antenatally, professional interpreter has to be required done. It should be hired up if required. If there is no language barrier is there, then professional interpreter is to be taken into consideration, not any family member. Okay. Then what should be offered her? Psychological assessment has to be offered. Screening for hepatitis C has to be done. Okay. Then reinfibulation will not be offered. This is an important question. Reinfibulation is prohibited. Assess her, document the plan. Midwifery care, if she has a history of a previous normal vaginal delivery and she is low risk, midwifery care can be done. Perineal tears in women with FGM should be managed in the same manner as in the women without FGM if there is no other risk. Okay. Recording has to be done in the red book, and if she is a girl child, safeguarding midwife has to be notified. All right. Please go through this chart very well, and any question can be coming here. Highlighted parts are very important. Okay. Okay, so this is a diagram which is showing how the defibrillation is done. This is also an exam question. Okay, type 3 FGM, that is closing, that is infibulation is done in this, showing the A diagram is infibulation. How do you do deinfibulation? Infiltration of the midline scar with the local anesthetic. Then you give an incision in the midline, and then you suture the cut edges with observable sutures. The cut edges may be oversewn with a fine observable suture, and a paraffin gauze dressing is then applied so that the opening widens up. Okay. This is an also a question which has been often asked. Okay, so this is FGM safeguarding pathway. Very important. You should know this. So if patient is presenting with FGM and she is under 18 and she's or a vulnerable adult, if you suspect she may be at a risk of FGM, what you should do is safeguarding risk assessment guidance has to be done. Risk assessment tool is there that has to be recorded. Okay, if she is under 18 years of age, police reporting is mandatory. If she is over 18 years of age, then you have to see if she has any female children or siblings who are at a risk of FGM, and you also have to complete the safeguarding risk assessment tool. Okay, now come here. Can you identify other female siblings? If she is at a risk, then identify her siblings as well or her family members who may be at risk. Risk assessment has to be done, and share this information with the multi-agency partners or initiate safeguarding response if she is found to be at a risk. Okay. Yeah, these are some health impacts of FGM. They are short-term impacts, long-term impacts. Go through the entire list. Hep B, hepatitis B, hepatitis C screening has to be done. HIV screening has to be done. She may have some other severe complications, short-term, like pain can be there. Psychological disorders can be there, urinary retention, and injury to the adjacent tissues, fractures, dislocations, and damage to other organs. Death can also be the short-term implication in severe cases. Okay. Long term, there can be infections, difficulty in menstruation, psychological damage again. Okay, all these long term implications can be there. Go through the entire list. Any one of them can be the questions. All right. Okay, I think we have covered the FGM guideline in details. Go through the entire guideline once again, refer to the questions. And if you have any questions, you can ask us in the Telegram group as well, or in the comment section also. I think you found this session helpful, and please go through the guidelines. Very important guidelines from exam point of view as well. Thank you so much.